The other major support system for the brain and spinal cord that we're going to talk about is the blood supply system. And the major dysfunction of the blood supply system to the brain is a stroke, a cerebrovascular accident or CVA. And we're going to talk about that. We work with CVAs a lot in rehab, and so it's something to know about, which is good. So we're going to talk about disorders of the circulatory system. I'm not going to really expect you to be able to diagram or describe in detail the circulatory system of the brain, but I do want you to be able to identify characteristic stroke signs by arterial location. So there are a lot of the stroke symptoms that are similar to one another, but each major artery has one sign that distinguishes it from the other arteries. So pay particular attention to those distinguishing signs, and I'll try to point them out as we go along. So loss of blood supply in a specific area correlates with a specific loss of function, which, I guess that kind of makes sense since the function of the cerebral cortex. So when we're table 26.1 in the textbook is the arterial supply of the central nervous system. And like I said, I don't want you to necessarily know this in detail, but it kind of gives you kind of planting the seeds for the next chapter when we talk about the areas of the cerebrum and their function. So the different arteries supply different areas of the brain, and so if you have an occlusion of that artery, you're gonna have effects that area takes care of. So just kind of plant that seed and take a look at that table 26.1 and see if it makes sense to you. And then when we talk about the cerebrum in the next chapter, take a look back at that chart and see if it makes better sense to you. So episodes are classified, episodes of brain ischemia or any kind of CVA, they're classified by the pattern of progression and the cause. So a transient ischemic attack is a brief focal loss of brain function with full recovery from neurological deficits within 24 hours. So a transient ischemic attack, if you look at the name TIA, transient ischemic attack, transient means it's brief and then it goes away. Ischemia means some place is being deprived of oxygen, and attack is obvious. So it's sort of analogous to angina pectoris in the circulatory system. Coronary artery is partially blocked and you get chest pain. With a transient ischemic attack, you get neurological deficits from a cerebral artery being partially blocked. And the main difference between a lot of times you'll see people admitted to the hospital and they'll say stroke or CVA versus TIA. So they're trying to determine, is this person having a CVA or are they having a TIA? And the way they're going to know is if the person has a full recovery within 24 hours, it was a TIA. That having been said, a TIA can be predictive of future strokes, just like angina can be predictive of future heart attacks, future myocardial infarction. So exactly analogous, just cerebral arteries versus coronary arteries. Cerebrovascular accident, or CVA, is the official name for a stroke. So we've all been taught probably our whole lives, if someone's having a heart attack, get them right to the hospital or call 911. Some members of the medical community are advocating us to call a stroke a brain attack. So people realize that they have to get prompt treatment. Prompt treatment may benefit some people who have strokes, just like prompt treatment may benefit people who have heart attacks. So if you have an ischemic stroke because you have a clot and you can get in right away and they give you the TPA, the clot busting drugs, it can extremely change your outcome. So you can go from having a not very many lingering effects to really horrible lingering effects if you don't get treatment right away. So a completed stroke is neurological deficits from vascular disorders that persist for more than 1 day and they're stable, they're not changing. A progressive stroke is where the deficits increase intermittently over time. So that is one of the ways that a CVA is classified, is whether it's completed or whether it's progressive. The two different types of stroke are an infarction, which is an ischemic event, and a hemorrhagic stroke. Okay, so keep that in mind. A brain infarction occurs when an embolus or a thrombus lodges in a vessel and obstructs the blood flow. So the embolus abruptly deprives the area of blood and it results in almost immediate onset of deficits. So that's the people will report to you that they were going along just fine and all of a sudden they were slurring their speech and they were having trouble walking. That acute onset is typical of a brain infarction or an ischemic stroke. Obstructions of blood flow in the small, deep arteries result in lacunar infarcts. The slow occlusion of an artery has a different outcome from an abrupt occlusion. That kind of makes sense, right? So the interesting thing that I read recently in some continuing ed that we had to do at the hospital was that 70% of people with ischemic strokes have high blood pressure. So we talked about the high blood pressure last quarter as being the silent killer. That's why. So that high blood pressure is just lurking to cause you problems later. So that's something you should keep track of. A hemorrhagic stroke, you have a hemorrhage of some sort, and the downstream vessels from where the hemorrhage is are deprived of blood. The extravascular blood also exerts pressure on the surrounding brain, and that can result in cell death. So generally, hemorrhagic strokes result in worse deficits within hours of onset, but then improvement occurs as the edema decreases and the extravascular blood is removed. So you get worse deficits initially, but they get better over time because you're relieving the pressure on the brain, basically. So the ischemic strokes are far more common than the hemorrhagic strokes. A subarachnoid hemorrhage usually causes sudden excruciating headaches with a brief loss of consciousness. So a lot of times findings aren't focal, meaning there's not one particular spot that is having an issue like it is with a CVA. The deficits are progressive because the continued bleeding or secondary hydrocephalus, and it puts pressure on the brain. Vasospasm and infarction are common sequelae, which are following events of a subarachnoid hemorrhage. So remember, the arachnoid is that middle membrane, and so this is bleeding between the arachnoid and the pia mater, and you can see how that would build up and put pressure on the brain. So the signs and symptoms of a stroke are going to depend on the location and the size of the lesion. That makes sense, right? So this list of neurological deficits have been reported to affect more than 25% of people surviving brain infarctions. So hemiparesis, which is weakness on one side of the body. Ataxia, so that's uncoordination. Hemianopia, which is loss of half of the visual field. Visual perceptual deficits. Aphasia, difficulty speaking. Dysarthria, difficulty with the motor part of speaking. Sensory deficits, and we'll talk about the difference between aphasia and dysarthria in a later chapter. Sensory deficits, memory deficits, and problems with bladder control. So all of those have been reported in more than 25% of people surviving brain infarctions. The effects that an individual person has, it's going to depend on the size and location of their lesion. So that is one thing that I find particularly interesting about working with CVA patients. And as I think most of you know, I work with a lot of CVA patients. I can have a day in the clinic where I have all CVA patients all day, and every single one of them will be different. Every one of them has different symptoms. Every one of them has different deficits. Every one of them has different abilities. And that's what makes it interesting. And every one of them has a chance to improve their function and have some kind of recovery. So it is amazing working with people with CVAs in the clinic. I'll just tell you that. So many of the the strokes that we see involve main arteries, smaller branches, the capillary network, or arteriovenous formations, where where you have different structures instead of the capillary network. We'll talk about it. So the vertebral and basilar arteries, if we go back to that chart, table 26.1, the vertebral artery supplies the spinal cord and medulla, and the anterior and the posterior vertebral part of the vertebral arteries supplies the medulla and the cerebrum. So 20% of ischemic strokes affect the brainstem and cerebellar regions. The vertebral artery is the chief symptom of it is pain, usually in the posterior neck or occiput, spreading to the shoulders. So the basilar artery, it affects the pons of the cerebellum, the midbrain, the occipital lobe, the choroid plexus of the third ventricle, parts of the thalamus and hypothalamus. So lots going on with the basilar artery. If you have vertebrobasilar artery ischemia, the most common signs are gait and limb ataxia, limb weakness, oculomotor palsies, and oropharyngeal dysfunction, so difficulty swallowing. The most common symptoms in acute cerebellar infarctions are dizziness or vertigo, inability to sit upright without support, difficulty walking, nausea and vomiting, dysarthria, and headache. Complete occlusion of the basilar artery can cause death, usually does, because it serves the brainstem. If your brainstem is not working, you don't have vital function control. So that's really bad. It doesn't work. So if you get complete occlusion of the basilar artery, you will not survive it. I have worked with people with vertebral and basilar artery strokes. One of my most interesting people that I worked with, well, they're all interesting, but one of them, a recent one, had a vertebral and basilar artery stroke and had what is called locked-in syndrome. And it is the only time in my career that I've seen locked-in syndrome. And all of the therapists that I work with, they said the same thing. None of us have ever seen it before. So when this person initially came in, they had time in inpatient rehab, and then came into outpatient. They could not move at all. They could move their head a little bit. That's it. And used that little head movement to control a power chair. The other thing, they couldn't talk, couldn't, obviously stand and whatever, because they couldn't do any of the movement. They used a letter board. They had glasses with a little flashlight on it, or a little light, and they would use their head to point the light towards the letter board to spell out words. So that was communication. So that's sort of the thing, locked-in syndrome. He was completely conscious of what was going on around him, but he couldn't speak and he couldn't move, so he was locked in. But there was that little window of communication, and that was amazing. In the course of the 3 years that I worked with him, he went from that to being independent at home with all of his ADLs, walking, talking, all the good stuff. And it was amazing to be involved in his recovery. Amazing. And part of the reason why he did so well is because he was unbelievably determined. and very stubbornly worked on all of his things and had lots and lots of challenges. But just you see that level of work and determination. Not only that, had a very supportive partner helping to facilitate all this stuff, and basically amazing recovery. So just that kind of thing keeps you going. That kind of thing makes you realize how important the work we do is. So of the cerebral arteries, this is a fascinating chart, I think. 69% of strokes are in the middle cerebral artery. Ischemic strokes are in the middle cerebral artery. So the things that we think of as typical stroke symptoms are middle cerebral artery symptoms. So, well, even though there are all those other ones that you could possibly have, that what we consider to be typical stroke symptoms are middle cerebral artery symptoms. So we'll talk about the specific middle cerebral arteries in a second. But the anterior cerebral artery, so this, if you have a stroke of the anterior cerebral artery, it is going to result in personality changes with contralateral hemiplegia and hemisensory loss. So you're going to lose motor function on one side, and you're going to lose sensory function on that side, and you're going to have personality changes because the anterior frontal lobe has has personality functions. Lack of blood supply to the deep branches of the anterior cerebral artery result in motor dysfunction caused by damage to the motor areas. You don't have to remember specifically what they are, but in the frontal lobe. So remember how in the motor chapter we talked about a motor act gets initiated in the anterior frontal lobe? If that's effective, that's going to result in motor dysfunction. So personality changes are like the determining symptom of an anterior cerebral artery stroke, or the distinguishing symptom. So you could have the hemiplegia and hemisensory loss in any stroke, and you can have motor dysfunction in any stroke, but those personality changes, that is the distinguishing symptom of an anterior cerebral artery stroke. Middle cerebral artery stroke, that's what we consider to be kind of our typical stroke symptoms, just because 69% of ischemic strokes are middle cerebral artery. So a stroke affecting the middle cerebral artery deprives the optic radiation and the lateral parts of the sensory motor cortex and adjacent white matter of blood. So the symptoms include homonymous hemianopia, which is that visual field cut, combined with contralateral hemiplegia and hemisensory loss involving the upper limb and face. So if your stroke is on the right side, you're going to have hemiplegia on the left side. If your stroke is on the left side, you're going to have hemiplegia on the right side. That's that contralateral. You can also get, depending on which branch is affected, you could get contralateral hemiplegia that affects the upper and lower extremities and the face, as well as aphasia. And we'll talk about the different types of aphasia in an upcoming chapter. But if you have if you have a left middle cerebral artery stroke, that's going to likely cause aphasia. Difficulty understanding spatial relationships, neglect, and impairment of nonverbal communication occur when you have a right middle cerebral artery stroke. So we'll talk more specifically about that as well. So these are sort of the things that we think of as typical stroke symptoms, and that's a middle cerebral artery stroke. The posterior cerebral artery can cause eye movement paresis or paralysis because it affects muscles that are innervated by the oculomotor nerve. It can also result in cortical blindness because it's posterior. It affects the occipital lobe, which is where our vision systems are. And the cortical blindness affects information from the contralateral visual field. So if you have it on the right, your left visual field is affected, and vice versa. Lack of blood flow to the thalamus with a posterior cerebral artery stroke can cause thalamic syndrome, which is characterized by severe pain. Remember, the thalamus is processing a lot of that sensory information. So if the processing's bad, that can be causing pain. Contralateral hemisensory loss and flaccid hemiparesis. So the contralateral hemisensory loss and hemiparesis, that can look like other strokes, but cortical blindness, that's the distinguishing characteristic of a posterior cerebral artery stroke. So you can have disorders of vascular formation that are called arteriovenous malformations. So it's a developmental abnormality where the arteries connect to the veins. So instead of having your normal capillary beds, you have abnormal thin-walled vessels that are larger than capillaries. Normally, you don't know you have one. They don't cause any signs and symptoms until they rupture, and then you have a hemorrhagic stroke. The bleeding causes dysfunction resulting from lack of blood to the area and the downstream vessels, and the pressure exerted by the extravascular blood. So you could have an arteriovenous malformation or AVM and not ever know it until you're running on the treadmill and it bursts and you die or have a severe stroke. So it's just in there waiting for you if you have one of those. So an aneurysm is a dilation of the wall of an artery or vein, and we talked when we're talking about the cardiovascular system about aortic aneurysms. You can have cerebral artery aneurysms. The dilation has thin walls that are prone to rupture. So saccular aneurysms are most common in the cerebral artery system. A Berry aneurysm is a little produces that little sac and has a thin connection with the artery. So as you can imagine, this could cause a problem if it bursts. Then you have a hemorrhagic stroke if an aneurysm bursts. So we have this cool system called the blood-brain barrier that is a specialized permeability barrier between the capillary endothelium of the central nervous system and the extracellular space in the central nervous system. There's a lot of stuff involved. There are a lot of cells besides just the neurons. There are tight junctions between the capillary endothelial cells that exclude large molecules. So normally in our capillaries, we have that one layer of endothelial cells, and white blood cells and whatnot can go through those openings to get out into the extracellular space. In the central nervous system, we have extra tight junctions between the capillary endothelial cells to keep larger molecules from getting into the brain. So the exclusion is useful for preventing pathogens from entering the central nervous system. It also prevents certain drugs and protein antibodies from accessing the brain. So remember those antibodies, they're those big immunoglobulin molecules. Well, they can't get across the blood-brain barrier. So a lot of medications, like the primary medication used in Parkinson's, the carbidopa-levodopa, it's a precursor form of dopamine because dopamine itself cannot cross the blood-brain barrier. So it's another layer to protect our brain. The blood-brain barrier is absent in the areas of the brain that directly sample the contents of blood or secrete things into the bloodstream. So like in the hypothalamus, we have sensors that are telling our oxygen level and our CO2 level. And so they're directly sampling the contents of the blood. So we don't have the blood-brain barrier there because we need to get access to the circulatory system. So there's some areas around the third and fourth ventricles that also don't have the blood-brain barrier. So there are cells that are called tanocytes that are made to separate the leaky regions from the rest of the brain to prevent proteins and viruses and certain drugs from entering the brain via the leaky regions. one of the things that happens when we're aging, why we're more susceptible to crazy things, is our blood-brain barrier becomes more permeable, the or more leaky, if you want to say that. So it's really cool. I think we have this cool cellular system to prevent things we don't want getting into our brain. So one of the reasons why it's hard to come up with treatments that have to directly affect areas of the brain is because of this blood-brain barrier. So the treatment for Parkinson's, for a while, they tried to substitute dopamine, and it didn't work because it couldn't get into the brain. And then they found the L-DOPA, the carbidopa levodopa, that could cross the blood-brain barrier and then was converted into dopamine. So it's a really interesting protective structure of the brain. So oxygen consumption increases from the brainstem to the cerebral cortex. So the cerebral cortex needs a lot of oxygen, and it's more vulnerable to hypoxia than the vital centers in the lower brainstem. So when you start getting hypoxic, you start getting confused and having motor difficulties, but your vital systems are still working because they don't need as much oxygen until it gets really bad. Um, so the cerebral cortex consumes a lot of oxygen. Cerebral arteries auto-regulate the local blood flow depending on blood pressure and metabolites in your blood. So the auto-regulation is super important to make sure that you get adequate blood flow to the cerebrum without getting brain edema. So you need enough blood, but not too much. Just like everything, right? It's a Goldilocks thing. We don't want too much, or we have edema, or we don't want too little, or we have hypoxia. So it has to be just right. And the cerebral arteries are doing that regulation. Cerebral edema is the accumulation of excess tissue fluid in the brain. So lots of different things can cause it. One cause can be a concussion, allowing fluid to leak from damaged capillaries. That's not good. Cardiac arrest can cause cerebral edema because the flow is affected. Going to high altitude, like really high altitude, not just going to Colorado, but like going to the Andes or the Tibetan Plateau or something, fluid pressure results in ischemia, causing arterioles to dilate and increase the capillary pressure, and that produces even more edema. So when you have cerebral edema, usually the things that are seen first are cognitive effects because the cerebrum needs more oxygen, and sometimes motor. Edema can be alleviated by shunts or medications, or in the case of high altitude cerebral edema, you go down, move to a lower altitude. So I was reading about high altitude hypoxia or altitude sickness is what they call it. And it said there are three cures for altitude sickness: go down, and go down. So the same thing with cerebral edema caused by high altitude. Going to lower altitude is going to relieve the problem. So you probably want to do that before it gets really bad. So if you're thinking about climbing Mount Everest, it's something to think about. So when you have cerebral edema, hydrocephalus, tumors, or other types of lesions, it can cause an increase in intracranial pressure. So intracranial pressure. So intracranial pressure above 15 millimeters of mercury is abnormal. Greater than 20 millimeters of mercury is pathologic, so it can cause problems. The symptoms are going to be vomiting and nausea. So remember with epidural and subdural hematomas, vomiting, nausea, headache, drowsiness, frontal lobe gait ataxia, and visual and eye movement problems because we're putting pressure on the brain. Lesions may produce a herniation of part of the brain. So that can increase intracranial pressure as well. So the reason that subarachnoid hemorrhage is bad is because it increases intracranial pressure. The reason cerebral edema is bad is because it can increase intracranial pressure. The reason that epidural and subdural hematomas are bad, same thing. So, and the symptoms you see are similar. So recognizing those symptoms as something that is needs to be taken care of right away, probably a good thing. So they use imaging to evaluate cerebral blood flow, positron emission tomography or a PET scan, or an angiography. Can also use an angiography or a PET scan to evaluate coronary blood flow. The PET scan is the computer-based image based on the metabolism of injected radioactively labeled substances. And an angiography consists of a radiopaque dye injected into the carotid or vertebral artery, followed by a sequence of X-ray images. So you get these cool images that can see what the blood flow is in the brain. The just like I was saying with the CSF system, it's not a closed system. It's a one-way system. The circulatory system in the brain is a closed system, just like the circulatory system in the rest of the body. So you get arterial delivery of oxygenated blood and then venous return of deoxygenated blood. So the major venous system of the brain consists of cerebral veins, and the veins drain into dural sinuses in the dura, in the meninges, and into the internal jugular vein. So two sets of veins drain the cerebrum, a superficial set and a deep set. And I'm not going to expect you to know specifically what areas are drained, but you could probably figure it out. So superficial and deep, and it drains it back into the vein system and returns it to the heart to go to the lungs and get oxygenated and go back up to the brain. So it's just like the rest of the circulatory system, it keeps circulating around.